is called the 52-year-old. Seen for a 52-year-old male with sudden onset of dyspnea, with pain between the shoulder blades while watching TV at home. Okay? So we're going to take these little bits at a time. So don't keep reading. Okay?
Late.
Too late? Gosh dang it. I wish I read faster.
Read the whole thing.
I'm a slow reader. Okay? Alright, so don't read down here, okay? So just read the first thing. Alright, patient's agitated, short of breath, with increased respiratory rate, and SaO2 at 89%. So, as we make this initial assessment, what are we thinking?
Cardiac.
Good.
Chick-fil-A.
Okay, am I gonna have to like take the little thing and start tossing it around you guys?
I actually meant to bring a ball.
Did you?
Yeah.
Oh man.
You toss my drink cups. There's that little piece of.
Oh, there's something you can throw over here behind the lungs.
Okay, so I heard a cardiac, right? Is that where we're at right now?
No.
Oh, we're gonna check some real manual dexterity, hand-eye coordination stuff tonight.
All one-handed.
So what are you thinking?
Respiratory.
Okay, good, because the person says dyspnea, right?
I was thinking PE.
But the
What are some key things here that you guys are watching for? What are the key things that are triggering you? Don't look to the bottom
Pain between
line.
the shoulder blades.
Sudden onset.
Boom, sudden onset. Excuse you, you got shortness of breath, right?
Sorry, should have waited.
That's all right. We'll put you in timeout. It's cool. You get it.
Darn.
So what other kind of things are we talking about or thinking? What do we want to know?
Aortic
Yeah,
aortic aneurysm.
History. Okay,
Oh.
it's very broad. I need something a little more specific than just history. What do you want to know?
Do you have any chest pain?
No chest pain.
That's
you got, man. That's all you get. Whew. Nice try though.
Does he have cardiac history?
No.
Can I ask another question?
No. There's so many people. So much fun. You guys better have something like, because so right now, we're in this stalemate, right? You're standing in front of the patient, and you're like, I don't know what to ask you right now.
So many questions.
All right, lost your turn. Here we go. You guys gotta be ready. Gotta be ready.
What is this? I guess we're.
It's a nonsense.
Holy moly.
Yes,
Do you have a respiratory history? Do you have any?
Yes.
What do you
now I
have?
have a
I
question.
have COPD.
What medications do you take?
I take albuterol inhalers.
I believe so, yeah.
Have you taken your albuterol already?
Oh yeah, multiple times.
How many?
Multiple. I can't even keep track.
How long ago?
Throughout the last hour. Nice. Here we go. This is what I like. I like people catching this.
The pain between your shoulder blades, does it extend to the front or anterior portion? I guess that would chest. Does it radiate all the way through, or just?
So does it move from my shoulder blades up into the front of my body too?
Yeah.
Maybe a little bit. Oh, jeez.
That's
I'm excited for the first person to drop this, by the way.
20 push-ups.
Heart and lung sounds.
Okay, heart. What are you listening for on the heart?
I'm listening to see if it's muffled.
Okay, what are you listening for on the lung sounds?
I want to find if there's any diminished or any sounds that are like rails or bronchi or bronchi.
So fairly clear, a little bit of wheezing, but you notice you got some decreased breath sounds on the right. So it says clear on the left, but we're going to give you, because we got COPD, we're going to give you, pass it to your left. I forgot that you had already asked one.
What were you doing before you were watching TV?
Before I was watching TV, I was asleep.
Whoa.
That was almost horrific.
You
Whoa.
dropped it. You're the first one to drop
You
it.
would have to make me.
It's like when I tell my kids, I'm just like, they're like, Dad, that was you when we're playing games. It's like, no, that was a bad throw. Come on, you gotta at least get it to me.
So skin conditions, what is?
Pale, dry, a little moist. I mean, it's kind of like on that threshold, kind of getting to that point. You understand when I say like on that threshold?
Yeah.
Like everything looks okay so far, but you notice that like part of the starting to get that little perspiration in little areas here and there. Kind of thing.
Are we just treating, or can we treat, or can we just ask questions?
You can treat if you want.
Okay.
That wasn't to me at all.
That was a bad throw.
That was a bad throw.
question.
What's the pain feel like? Can you describe it?
It's just like it's like a sharp pain.
Okay.
Man, what is the man? There is a
So many
question.
questions.
that
I have
is-
like so
that is-
many.
That is.
I just want-
Josh.
I have like 5.
Oh, Josh. All right, hey Josh, you have 10 seconds to ask 3 questions. Go. 1. Do you have a history of blood clots? No. 3.
Do you take a blood
4.
thinner?
No. 5. 6.
What's your temperature?
7. 8. I don't know what my temperature is. Yes, you can take the temperature. It's 98.6. Ooh, good job. All right, so that's the kind of thing. You gotta have questions in reserve to be able to fire off questions really fast, right? Because somebody that's going like. Are you short of breath? Like as they're like basically gasping to breathe and survive, right? So you gotta have those throwdown questions, okay? Oh, geez.
Oh, wow.
Man, I about took your head off. I apologize. I'll throw it with my left hand next time.
Have you had this pain before?
No, never.
Can we get EKG?
Sure you can. What do you think the EKG is gonna say?
Sinus tap.
Man.
Does anything you do make the pain better or worse?
Yeah. What? Nothing. I did, didn't I? Oh, you have more questions? Need clarification?
What makes the pain better?
When I can catch a good breath.
Is that all? Can I ask what makes the pain worse?
Yeah. When I can't catch my breath.
Okay.
Well, it's gonna be that way.
But that, you know.
Yeah, that's why I said it's gonna be that way.
Commie bet. You wanna put him on commie bet? Sure.
Oh. That was you.
Man. So, boom. So I dropped it. So I'm gonna give you.
Oh, 3.
I'm gonna give you the big question that I've been looking for you guys to ask. Oh, you wanna try in? Okay. Okay. You guys wanna make a wager right now? You
Yes.
have one chance to ask the question that I'm going to ask.
Oh, she's
And then-
Oh, I put my money on Annalise.
Everybody put their money on Annalise?
Yeah.
Okay.
Hell yeah. It's right there.
We were told not to look at the board. Are
I
we
know.
allowed to look at the board now?
No, not yet, but it's 98 over 62.
10 questions.
98 over 62.
I still believe you,
girl.
So how many people want to go back with Annalise now?
I always bet on Annalise.
You caught it with your neck.
Is there any JVD or tracheal deviation?
No, there's not.
I have another question.
If it doesn't help, like I can tell who's not making eye contact with me. Like, Levi over there hiding in the corner.
Yeah.
You missed me, haven't you?
Of course.
Okay. So, okay, you guys, let's see, everybody else has asked questions besides you two back there, right? Everybody else has had the
Tommy?
opportunity?
Maybe.
Okay, we're down to the last 2 questions, and you guys better hit. No, you're
I
out.
have one.
You are gone, Annalise.
Please.
Pain scale 1 to 10. What's your pain? 10 or worse than your whole life.
It's like a 3 or 4.
3 or 4.
Good. How tall are they? As tall as me.
I'm 6'3".
So you got. Okay.
One more, please.
Give her a shot.
Should we get it?
Yeah! Annalise, I'll bet on me.
So what are you guys willing to wager now?
Like real
Are
money?
you guys willing to
I'll
wager?
give you 3.
Are you willing to wager your first job?
Oh, wow.
Yeah.
I already have a job.
Well, that's the thing. Are you willing to wager your job right now?
Oh, yes.
See, that's the thing. That's what I always ask my probie. Like they come in and they're like, hey, I got a question for you. I'm like, okay, I got an answer. So I give them the answer, and then I'll be like, I got a question for you. And they're like, okay. I'm just like, and I'll ask the question, and I'll stop them where they answer. I'm like, do you know the answer? And they're like, yeah. I'm like, okay. Are you willing to bet your job on it? And they're like, I'm like, because I only want to know if you're that confident in your answer. And they're like, I was like, because who knows? I mean, I never try and trick people, right? So it's one of those things. It's like, and everybody, so a new probie showed up the other day from another shift, and he fired off the same kind of question. And I was just like, oh, are you willing to bet your job? And my probie comes running in from like the other room. He's like, don't do it! Don't do it! Yeah, this is it. Job's on the line. All right, so here we go. We're gonna move on. General impression of this person.
Sick.
Sick? Yes. Why?
89%.
dyspnea, pain, SpO2, low BP, high heart rate. High heart rate with that low BP.
Starting to show signs of shock.
Shallow respiration.
Okay, good.
Oh,
Everybody
decent
catching all that.
treatment.
So we're having low O2 sets, starting to begin signs of shock. Pressure, it's not ideal. It's not horrific though, right?
Right.
But it's not on the super high end. It's not on the super low end, right?
But I would expect somebody 52 with history of COPD to not have a low blood pressure.
Okay. What else are we looking at here that's throwing out some red flags for us?
The heart rate
52
high with
shallow.
a low
Good.
blood pressure.
So remember what the first thing that the body does when it starts to freak out, right?
Tries to
When it starts to have issues, it
Decompensate.
starts to compensate. So one of the first things it does, if we're low on oxygen, the heart tries to help fix it, right? So it's gonna start picking things up. Plus, you're gonna have anxiety from shortness of breath, right? Somebody can't breathe, next thing you know, they're getting a little tacky, right? Respiratory rate, abnormal.
Yep.
Quality,
Shallow.
abnormal.
Yep.
Okay, so what is our impression? What do we think is wrong with this person?
Possible PE, possible pneumo.
Good. Which one can we do anything about?
We can do something about a pneumo if it's tension.
Okay. So how are we gonna tell if it's a tension?
We're gonna look for our signs, sub-Q emphysema, tracheal deviation, JVD, or hyperinflation.
Oh, man. All right, so in some of the other things we talked about like cardiac tamponade last term, right?
Right.
Did we hit pneumothorax stuff, hemopneumo, tension pneumo? Did we hit that in that discussion? Cool. I was hoping we had, but everything kind of ran together. So, all right. So moving on. So this is our thought, right?
Yep.
Spontaneous tension pneumothorax. You guys agree with that?
Yes.
Yes.
He didn't have the trachea.
Speak out loud. Don't be afraid.
Oh, not
He didn't have
tension.
any signs.
Don't worry, I won't come after
Of
you,
tension.
everybody. Right? So are we two attention pneumothorax?
No,
No.
we're
No.
to
Not
maybe a
tension.
pneumo, but no tension.
Are we at a full-fledged pneumo yet?
No.
Possibly we've got diminished.
There we go. So, the question that I would have asked at the very beginning, that I was just, I'm like, please, somebody just ask it, is I want to know, with this sudden onset, right? So yeah, you're watching TV, like, what is the timeline from when you had this sudden onset to right now, and what events occurred during that sudden onset? Okay? So if you have a COPD patient, what do they commonly have?
A cough.
A cough, right? So they have coughs associated with it, right? And we have talked about blebs, right? So those are the most common cause of non-traumatic events for pneumothoraxes, okay? So
Can you define a blep again?
So you have your alveoli. So alveoli, they lose their elasticity, right? So the elasticity gets worn out, so the alveoli continue to inflate, but they lose that recoilability, right? So if you continue to increase the air trapping that goes in, and then you increase the intrathoracic pressure with a cough, what's it gonna do?
Pop
Pop. Then where's that air go?
into the pleural space.
Okay? So then, you're now putting air into this chest wall cavity, right? How much air can that take? Well, when it first happens with a little like coughing attack, you end up with what kind of presentation?
Pain, shortness of breath.
Because you've got something that's not supposed to be there.
There we go. See? So something's discomfort, right? So you have some sort of crazy, weird discomfort. Diminished lung sounds because that air is starting to take the place on the outside of the lung versus the inside of the lung, right? So you start to develop a simple pneumo on it.
So when you have something like that happen initially, and they're getting that sudden onset of sharp pain, and that air is going into that pleural space, is the pain that they're feeling basically the separation of those two walls? Like the nerve endings are being triggered, and you're feeling that separation where that air is getting into that pleural space?
The pain aspect of it, yes. The discomfort, the urge to
Everything else.
breathe is associated with your actual lung and inability for your lung to inflate. Okay, everybody tracking?
Would you still have lung sounds if it was pleurisy?
Pleurisy? What is pleurisy?
The separation of the lining of
Okay.
the lungs and
So what is happening to your lungs? Are they flat? Are they deflated? Are they gone?
deflated.
Is there air still moving in and out of your lungs?
Yes.
Okay, so your lungs are totally fine. All it is it's the outside layer of your lung that's rubbing. Okay, so you're just gonna hear like you can find it on the Google. You can Google it. Just Google pleurisy. It's just kind of like they call it a pleural friction rub, and all it is a different type of lung sound. Okay, and so they're very specific in places. You can only really hear them over the area that's, usually it's an inflammation that has caused it. And so if you're in the ICUs, ICUs are great places to find pleuritic rubs. ERs, not so much, right? And so there will still be great lung sounds because there's nothing affecting the lungs as they breathe in and out. It's just the outside rub that you're hearing. Make sense? Yeah?
Would this person be able to take a deep breath if they tried?
Mhm.
Or,
I've probably heard.
Yeah. So that's where they get the discomfort, right? Because as they take a deeper breath, what happens?
More air is going.
More air goes into that pleural space, right? So they're breathing faster, they're trying to breathe deeper, but now that it's getting shallower because it hurts. So more and more air is going in, faster they breathe, more air goes in, what's gonna potentially happen?
Tension.
More and more tension.
Can you put unlimited air into the thoracic cavity?
No.
Because what happens?
It's going to tension and it's going to lose. It's not going to have any more space to go.
Right. So what does it do? What does this air do?
Shift
Shifts
over.
over.
It collapses that lung because now the interthoracic pressure is greater on the outside of the lungs because you keep putting air in, putting air in, the pressure builds and slowly starts to shut off that lung or collapse that lung. All right. So that's where your spontaneous pneumothorax is, which is a good question with the height back there, because certain populations actually can develop spontaneous pneumos much quicker than others. Okay. So those are the types of questions that you want to get to, association around the actual event. When there's this acute onset of anything, you're like, all right, something happened, boom, just like that. I want to know everything that happened within the last 5 minutes. Because I want to know because I mean, it's very random for something just to acutely happen just like this for no crazy reason, right? So if I do my quick questioning over the last 5 minutes and I find nothing, now I'm like, okay, now I broaden it out a little bit, right? And I keep moving further and further away, building my case for what it is. So in this type of situation, if nothing happened through those first 5 minutes, I'm going to back up even farther and be like, okay, I didn't get the answers that I wanted during that first 5 minutes. I'm going to get specific. I'm like, hey, so you got COPD, have you been sick, have you had any sort of coughing attacks, anything like that? And if they say no, okay, now I'm like, whew, okay, reevaluate, right? So what were the two things we were concerned about? So now, boom, I'm bumping back over to the PE approach, and now I'm going to do a couple questions on PE, right? So what kind of questions would I want to ask this person in regards if I'm trying to rule out a PE? Chad.
Feel starved for breath or just having difficulty breathing?
Okay. Mark.
History of clots, surgeries.
Okay, that's already taken care of.
Uh,
Josh asked it in rapid fire. He blacked out. Everybody else blacked out
Oh.
because Josh was on fire.
We're asking
Same person.
same person.
Same person.
Okay, so is it pinpoint pain where they can feel where that spot is?
So everything that we've already asked has been asked, but we want to get more into, let's see, who was it over here that said history? Brooke, right? There's a lot in the history that we want to know about, right? So if we're thinking PE, PEs don't normally just happen, right? Usually there's some sort of underlying condition, the blood clots, AFib, something like that. Or, what are the big things that cause PEs?
recent travel.
Recent travel
Air
and
travel. Prolonged.
Or prolonged
Is there
downtime?
Is
or
it a hot,
surgery?
warm leg or arm? Is there?
what?
Prolonged sedation.
Okay? And any sort
Is
of
there-
hospitalization, surgeries, anything that could potentially cause clots, okay? Infections, recent infections, anything like that. So those are the quick questions, boom. I'm gonna run through those ones really quick, right? Because I want to be able to differentiate, am I going PE route or am I going pneumothorax route? Does that make sense? Is everybody tracking? We cool? Yeah? All right. So here we go. Going back. So now, oh,
Where did the pain in the shoulder blades come
because it's there.
Referred
I'm starting to get interthoracic air movement, pushing, nerve, affection.
You can have a hole or a back, not a certain
How are you,
There's one
when you're looking at this, how are you differentiating that you want to go your respiratory route versus your cardiac?
Ooh, yes.
Because I was real stuck on the cardiac.
Yeah, so, boom, let me go back a little bit. So there's a lot of things here that are sending me down my respiratory route, right?
Right.
Respiratory rate, 32, right? Can you have that with cardiac related events? Yeah. Most of the time, are you gonna end up with shallow respirations? Not usually, right? Usually your respiratory pattern still stays the same. Your rate may increase because you're trying to get that oxygen, but your tidal volume isn't going down for some reason, okay? How about up here?
Lung sounds?
Lung sounds are the big one that are keying me into something here, okay? You got poor lung sounds and low sats. Usually in a cardiac event, your sats are fine. The only thing that's really gonna key you off to it is your blood pressure, right? Because your pump isn't pumping as well. It's not necessarily gonna affect your sats because you're still getting the 100% sats going through that, right?
You'd have CHF, you'd have crappy lung sounds though, right?
You would, yes, well, I mean, depending on how
How full
far
they
you
are.
are, where you are, how full they are, new onset or old onset, how long they've been compensating.
But I guess that would be
So,
a combination of heart and lungs.
Yeah, so, can you completely rule out cardiac in this event?
I was thinking maybe possibly both.
Yeah, so you absolutely have to run a 12 lead on this person. You have to do the workup. So what do you, so are you gonna give this person nitro and aspirin?
No.
Let's say instead of having the pain in the shoulder blades, they say they got pain right here.
But
Who wants to give aspirin? Man, you guys, see, you guys are gonna be paramedics after all. How about nitro?
Do you have an IV established?
I got, yeah, no IV. Okay, yeah, you're awesome, you got an IV.
No, because we're determining the underlying causes of lungs. So.
Okay, so that's the kind of thing. So there's questions associated with this chest pain that you want to ask. There should be, at least, if you were amazing paramedics. I mean, right now you guys are good paramedics.
Type of pain.
So what do we revert back to anytime we have pain? What questions?
OPQRST.
Okay, so there's things associated with that. And what are some of the questions that I tell you guys to ask every time to try and differentiate between respiratory and cardiac? Does it change with inspiration? Does it change with movement, right? Anytime so what happens if somebody has a partially collapsed lung? Do you think that if they move, do you think that's gonna make things worse? Like it's gonna hurt more? Absolutely, right? Because you move, interthoracic pressure changes, your nerves are affected, increased pain, right? If they have cardiac chest pain, is movement gonna affect any of that? No, it's they're having the pain because they're not getting enough oxygen at the heart muscle. Make sense? But can you move on from cardiac without doing a full workout? Absolutely not. You have to do your 12 lead. You have to get better at your OBQRST in your question. Make sense? Cool? Is everybody following? Yes.
I got questions about the treatment. So,
Don't we all?
yeah.